it's my privilege today to introduce our Grand Round speaker, Dr. Fred Starr. Dr. Starr comes to us originally from Santa Monica, California, where he was born and raised. Then actually has his bachelor's in history from Duke. Went on to Jefferson Medical College, graduating with honors from there. Did 2 years of research at UCLA, followed by residency at Rush, in which he was a 7-year resident because he also did 2 years of research at Rush in surgical oncology. I was fortunate enough to have Dr. Starr as my chief resident in the 3rd year, so he taught me everything that he knows, and then I was even more fortunate to have him then as a trauma fellow at Cook County Hospital. He finished both trauma and critical care fellowships at Cook County and has been a trauma attending there since 2006. He's currently chair of the Division of Trauma Administration at Cook County, and many of our residents have now gotten to meet and work with Dr. Starr. Perhaps even more importantly, he's grounded by a wife who is an OBGYN, and I was fortunate enough to have her deliver my first child while I was in Chicago. Also has 2 daughters. But again, without further ado, Dr. Fred Starr.
Thank you, Mel. Yeah, Mel actually got pulled out of M&M for her first child when it was born. So one of the other residents went out and ran off to the hospital. My wife delivered her first baby, who I got to see again probably for the first time since delivery last night. So that was great. Thank you all for inviting me. It's a real privilege to be here. I've heard a lot about South Dakota, never been here before, but Mel certainly said a lot of great things about Sioux Falls, and now I see why she wanted to come back here rather than stay in Chicago, which we would have loved to have her stay in Chicago. It was great seeing a lot of you last night. We had a great dinner. I learned what chislet was, and also we have drinks that have bacon in it, which was also pretty outstanding. And it was good to hear some stories of the older days at Rush, and also see some of the faces that I've seen at County as we've started a partnership and training some of your residents here and some of you guys. And it's good to see you. I know some of you were guinea pigs, and it's good to see you're still thriving and actually coming back again. So we're glad to maintain that relationship and keep that strong. So today we're going to talk about a topic, or this morning we're going to talk about a topic which I've been interested in for a number of years. One reason is that this is the old Cook County Hospital building. We're in a new building now, which looks a lot better than that. But this is the old hospital building. And in 1937, Dr. Bernard Fantis was one of the pioneers of the blood bank. And the first hospital blood bank in the United States was actually at Cook County Hospital. Started in 1937, right before World War II. And that actually paved the way in order to have blood that was going to be available for our troops overseas. So that was a huge advancement as far as resuscitation goes and the delivery of blood products for our soldiers in need. So why are we talking about hemorrhage? Well, it's actually the number 2 cause of death for trauma patients, number 1 being CNS injuries. Number 2 are patients who are dying of exsanguinating hemorrhage. So of patients that actually make it to the hospital and those that die within the first few hours, most of them are going to die from hemorrhage. Of the patients that make it to the operating room, most of those patients that end up dying in the operating room, a huge majority of those patients are going to die from hemorrhage. Also, there's been a lot of press lately as far as preventable deaths, and preventable deaths are generally hemorrhagic deaths. So there's been a lot of interest in tourniquets now. The military all uses tourniquets. There's been a lot of interest in the civilian world about using tourniquets. Chicago Fire Department just this last year has added that as part of their SMOs. So now they're applying tourniquets to penetrating extremity trauma, and we're seeing more and more patients coming in that actually have tourniquets placed, usually with correct indications, not always so. And there's also a big push in the American College of Surgeons for Stop the Bleed.
Okay, no, I'm sorry.
There's a big push in the American College of Surgeons. There's a program called Stop the Bleed, which is actually educating the public on mechanisms and ways and strategies to stop basic hemorrhage in the field prior to that patient getting more professional care. Hemorrhage is not just in the trauma setting, so it actually applies to other areas as well. And probably you'll see massive hemorrhage is what we're talking about today, and massive resuscitation, which we'll talk about a lot more today. And you see it in other areas like complex surgeries, particularly transplant surgery, some cardiothoracic surgery. You see it in postpartum hemorrhage. It's actually the #1 cause of maternal death in the United States is postpartum hemorrhage. We get called on a lot of cases where they have really bad placenta accreta and they have terrible bleeding in the operating room. They call us to come help out in the operating room with the OBs, and we manage the resuscitations at county for these patients who are getting the massive transfusions, because we do them a lot. We do about 75 massive transfusions for our patients a year, which is a pretty significant number. Other areas, we're seeing a lot more patients that are coming in on some of the novel oral anticoagulants, apixaban, rivaroxaban, dabigatran. They're great, but the reversal of those agents not so good, and we're seeing a little bit more bleeding from that. So these are a number of the areas where we're seeing a lot of hemorrhage. Getting back to trauma, this is the trimodal death distribution. And again, why are we focusing on hemorrhage? Because this was data actually from the early 80s, but it's still relevant today. So this first peak here, so this is time course from injury. This first peak, these are people that are dying right at the scene. So generally it's CNS injuries, traumatic brain injury, high spinal cord injury, but also a large percent of those are dying from hemorrhage at the scene. But unfortunately, there's no providers there's no intervention that we can do there. All we can do for those patients to reduce this peak is prevention. So that's where trauma centers, level 1 trauma centers, have a real mission out there in the community to educate on using seatbelts, airbags, proponents of car seats for children, helmets for bicycles, motorcycles, etc. This later peak here is several weeks after the original injury. And those are patients that are dying in the ICU from consequences of their injury. So they're not dying of hemorrhage, but they're dying of things like multiple organ failure, infection, they're dying of pulmonary embolism. It's this peak right here, a couple hours right after injury that happens. This is the one where we can have the most effect if we know exactly how to resuscitate these patients, and these are the ones that are dying from hemorrhage by and large. So this is the peak. If we can figure out better strategies to resuscitate these patients, we can actually reduce that peak. So the idea of the golden hour, probably everyone is familiar with. Well, it wasn't called the golden hour back then, but this is actually data that came out in 1918 from a French surgeon who noticed after World War I that patients, the longer it took for them to get to medical care, the worse their mortality was, which seems intuitive, but it seems like the first couple hours, patients did okay, and then if you went much beyond that, mortality skyrocketed. But it wasn't until a little bit later when this is Dr. Crowley, who was the founder of the Maryland Emergency Medical System, as well as founder of Shock Trauma, which is one of the first trauma centers. There's a little rivalry between is Cook County the first or is Maryland Shock Trauma the first. I think we are. They think they are. But he was a cardiac surgeon in the days before heart-lung bypass. So he was no stranger to seeing patients go into shock, either from hemorrhagic shock on the table or from cardiogenic shock. And he noticed that in these patients who were in shock, even though he was able to get them back, that there was a momentary pause in the act of death. There's a golden hour between life and death. If you're critically injured, you have less than 60 minutes to survive. You might not die right then. It might be days or 2 weeks later, but something has happened in your body that is irreparable. So this is where the first term use of the golden hour actually occurred. Probably it's a little bit longer than 60 minutes in reality. Probably 60 to 3 hours, probably. But something has happened. Even though the patient seems to come back to life, you're able to resuscitate. Something has happened with the physiology in that patient that no matter what you do at this point, they're still going to die. So trauma literature, unlike all other literature, like all other literature, there's all kinds of definitions out there. So let's just get kind of standardize some of the definitions that we're talking about. So massive bleeding is more than 1 blood volume in 24 hours. Maybe a more accurate and appropriate definition would be 50% blood loss within 3 hours, but this is pretty standard in literature. What is a massive transfusion? Pretty standard is more than 10 units of packed red cells within a 24-hour period. Some literature is actually looking at maybe 12 hours, and even as little as 6 hours, but most is between 12 and 24 hours of 10 units of packed red cells. Of patients and casualties in the military, about 7% are going to receive a massive transfusion. Fortunately, that's a lot lower in the civilian world, about 1 to 2%. So of trauma patients that come to the hospital, only about 10% receive any blood transfusion. And of those, about 10% are going to receive a massive transfusion. So what is 1 blood volume? So just so we're clear, 7% ideal body weight, which comes out in the normal person that you never see at 70 kilos, about 5 liters of blood. So we're living in the days of component therapy. We don't give whole blood anymore, usually with some exceptions, but in general, we're not doing whole blood anymore. That changed in the late 70s to component therapy. And what does that translate as far as the blood volume of component therapy? It's about 9 units of packed red cells and 11 units of FFP would be 1 blood volume. So we're talking about losing this much within a 24-hour period. This is the ATLS classification of hemorrhage. Probably most of you are familiar with this. It's broken into 4 different groups. What we're really talking about is class 4 hemorrhage. These are people who've lost over 2 liters of blood, 40% of their blood volume. They're markedly tachycardic, they're hypotensive, and notice hypotension doesn't show up until you've lost 1.5 liters to 2 liters of blood. So that's a late finding. So once they become hypotensive, you're kind of behind the 8 ball already. And their mental status is declined. So these are patients very easy to recognize when they come in. These are class 4 hemorrhage. So damage control, unfortunately, surgeons can't take credit for the term damage control. It actually originated in the Navy in the late 30s, early 40s. My history major is coming out. I did a lot of study on around the peri-World War II period. So the term damage control really came from the Navy. And basically, it's their capacity to keep a ship working, absorbing whatever damage is thrown at it, so that it's able to maintain its mission integrity. This is a picture of the USS Yorktown, actually, which was damaged at Coral Sea. It limped back. They had 3 days to put it back together and patch the holes and get it functioning again, just basically so it could perform its mission. And they sent it right back out to the Pacific, and it joined the fleet, and it was able to contribute to the Battle of Midway, which was probably the turning point of the Battle of the Pacific. So they were able to just have it maintain its function, get it back out there and function. So how does this apply to humans? Well, our mission integrity is staying alive. So basically what damage control for us is, it's all the strategies that we employ in order to preserve that main mission, which is basically preserve life above all else. So damage control is resuscitation is the strategy that we employ in order to actually maintain that life. And it's made up of several components, and they're happening concurrently. So it's a whole system, it's a whole set of interventions, resuscitative strategies that are designed to prevent the physiologic changes and derangements which happen to the severely injured patient. So bleeding control is certainly one element, and there's a number of strategies that we use in order to get very quick bleeding control. And then there's a coagulopathy which develops in trauma patients, both because of things that we do to the patient, plus they come in with a coagulopathy as well, which is caused by the trauma itself. And then the resuscitation that we do has to focus on this coagulopathy, otherwise you get behind the 8 ball, and we'll talk a little bit about that. And these 2 areas altogether encompass a damage control resuscitation. So this is actually the first article which described the lethal triad, which everybody in trauma knows, and probably most people in surgery know, the combination of hypothermia, acidosis, and coagulopathy. And together, and interesting, this is actually the actual article from the Journal of Trauma in 1982. So this is the kind of graphic that was in there. It looks like it was drawn in the back of an envelope and sent into the manuscript. So the standard's a little bit higher now. But anyway, but the gist of that, I mean, this was really groundbreaking, showing basically they looked at penetrating vascular injuries. And they noticed that in patients, they were able to get vascular control, that over half of those patients, even though they had their artery tied off, those patients continued to bleed, so they developed a coagulopathy. And they looked at what are some of the common features of these patients that developed this coagulopathy. And they found that those patients, they were hypothermic, they were acidotic because they were in shock, they were producing lactic acid, anaerobic metabolism, lactic acidosis, worsened their acidosis, and these together worsened their coagulopathy, caused more bleeding, which caused more hypoxia, and then round and round it goes. And they called this the bloody vicious cycle of trauma. So what damage control resuscitation really is trying to do, and one element is you need to prevent this ideally from happening. So addressing this proactively rather than reacting to all of these features that are causing this coagulopathy. So this is the lethal triad. So really the philosophy is stay out of trouble rather than get yourself out of trouble. So you want to preemptively anticipate the acidosis, anticipate the hypothermia, and what are the strategies we can do in order to make this not happen so that we don't get this terrible coagulopathy. I can't do this talk without bringing this up. I know this gives everybody the excitement of looking at the intrinsic and extrinsic clotting cascade, but there's a couple of features on here which actually are fairly important to remember. You guys probably remember a lot better than we all remember it here. But they meet in a common pathway where with generation of thrombin, which converts fibrinogen to fibrin and forms a nice stable clot right there. And that's kind of the ultimate goal right here. There's these areas in green here. These are complexes that form. So these are all enzymes, and it's a nice dance that they all have to perform together in order to get to this end result. These complexes form, and without these complexes, this happens much, much, much slower. So you have to be able to have these guys bind together in order to make this process happen quickly. And then you also need to make sure that you get enough fibrinogen, making fibrin and making a nice stable clot. So what happens with acidosis? Well, as the pH goes down, it makes these complexes break up. So this whole clotting cascade is not even happening anymore. Or it does happen, but much, much slower. And when you get down to a pH of 7.1, all of your enzymes are not working nearly as well as they would at the normal physiologic pH. Thrombin activity decreases. Factor 7 is something we used to use a lot more, so we did Nova 7. I'll talk more about this a little bit later. But Nova 7, something we can't, it works great at pH of 7.4, or at least in the lab, it works great at pH 7.4. But when you get down to 7.0, it loses about 90% of its activity. So our pharmacy wouldn't even release it to us unless we had a pH 7.2 or better. So we do all kinds of things, give them lots of bicarb, and we get that one value, and then we get it from pharmacy and give it, and then they infarct their lung. But we'll talk about that in a little bit. So also acidosis has a big effect on platelets. So platelets, they change shape with acidosis. If they change shape, they don't aggregate, they don't activate, then they can't stimulate the clotting cascade. So that's a big problem. This is just basically showing the generation of thrombin at decreasing pH. So when you get down to about a pH of 7.2, your activity of your thrombin generation is about half what it is at normal physiologic pH. So really a decrease. And thrombin, remember, that's what makes fibrinogen go to fibrin and makes your clot. So hypothermia. So that's one of the other vertices of the lethal triad. So we are, as trauma surgeons, the traumatic patient comes in with a number of reasons to have hypothermia. So one is their thermoregulation is disrupted just from being a trauma patient, but we also do things to them which makes it even harder for them to maintain body heat, such as we give them paralytics in the operating room so they can't shiver, so they're not going to generate their own heat. Also, when they're injured and we're anesthetizing them and sedating them, their metabolism actually goes down initially, so they're not generating that intrinsic heat. So intrinsically, they're behind the 8 ball, but also the environment. So I know we talked a lot about minimally invasive surgery this morning. Well, we're maximally invasive surgeons. I don't do a lot of laparoscopic surgery anymore, but we do big incisions, and all of our trauma patients, they need to be prepped from basically the nipples down to the knees. So not a lot of room to put bear huggers and keep that patient warm in the operating room. So when you open up several body cavities as well, there's a lot of heat that gets lost. So every hour that we're in the operating room, we're losing almost 5 degrees of body heat. So they get cold very quickly. And this is one of the reasons why staying in the operating room for too long for a badly injured trauma patient is not the place to be. You need to get out of the operating room. And that leads to something we'll talk about a little bit later in damage control surgery. Hypothermia for trauma is core body temperature less than 35 degrees. Mortality approaches 100% when that core body temperature gets less than 32 degrees. There's just nothing clots anymore. And then you enter that bloody vicious cycle of trauma. And once you get into that, it's really, really, really hard to get out of it. Probably hypothermia has even more of an effect on platelets than it does on some of the clotting factors. Although if you look at, this is decreasing temperature, these are some of the main players in clotting. At body temperature 100%, as you start decreasing below 33 degrees, 31 degrees, almost no activity from any of the clotting factors. So really you can see none of that whole clotting cascade is working when you start getting cold. And it is not hard to get a patient to 32 degrees when you're in the operating room. For us, at least. For you, you're able to put bear huggers and you keep the room warmer and things like that. But for us, it's not uncommon to get patients, they start getting colder and colder the longer you're in the operating room. This is just to remind you that when using the traditional mechanisms to evaluate coagulation are not that accurate in trauma patients. So when we send samples off to the lab, they heat them up to 37 degrees and then they run those samples. So our patients are not at 37 degrees often, so their clotting factors are not going to be working as well as they are in the lab when they're running PTT, for example. So as the body temperature gets colder, or you run those samples at colder temperatures, that PTT actually goes up. So sometimes you can get a false sense of security by looking at some of these coagulation indices and think, oh, it looks normal, but that's an artifact because the lab is actually heating up that sample. So often the patients are worse off than what you think. So platelets, as I mentioned, are very sensitive to temperature. They don't bind, again, just like with acidosis, they're not binding together, they're not getting activated, they're not stimulating the clotting cascade. The only way to reverse this, unfortunately, there's no magic bullet, there's no drug that we can give, it's got to be rewarming strategies. So there's active and passive rewarming strategies. Again, we have limited areas that we can put bear huggers when we're in the operating room, but some of the things that we try to do is we limit our amount of time in the operating room. We keep the operating room up to fairly warm, uncomfortable temperatures for us, but it's good for the patient. All fluids are given warm, so we have blood warmers. They can just transfuse a unit of blood in less than a minute, or a liter of saline in less than a minute. All fluids are warm. We warm them up at 40 degrees. So you need to give warm fluids to patients, otherwise they're going to get cold very quickly. And then the third point of the lethal triad is the coagulopathy, which develops. And again, the acidosis, the hypothermia lead to the coagulopathy. And traditionally, we always thought that the coagulopathy was something that we did to the patient. It was an acquired coagulopathy that happened from basically giving a lot of crystalloid, which dilutes out the clotting factors, or the hypothermia, which develops because of the reasons we mentioned before. Other factors, the acidosis, which develops from anaerobic respiration and being in shock. And then these clotting factors, they all get used up. So actually the end effectors of the clotting cascade aren't really present in very high concentrations. There's only about 10 grams of fibrinogen in the body. So that can get used up fairly quickly if you've got a lot of tissue injury. So everywhere you have tissue injury, that clotting cascade is going to start getting activated, and those last little effectors of your clotting cascade are going to get used up in those areas, and then you don't have it. But what actually was recognized, so not just the acquired coagulopathy, but about 10 years ago, they started to see that some of these patients are coming in and they're actually coagulopathic before we even do anything to them, before they get cold. So most patients, when they come in, unless maybe they're in South Dakota and they've been outside for a while before they get to the hospital, and in Chicago as well, they usually come in and their core body temperature is fairly normal. Then they get cold from the stuff we do. So they show up, not hypothermic, and we haven't given a lot of crystalloid, but they still have some kind of coagulopathy. So there's something that's happening in these trauma patients which makes them coagulopathic before we even do anything to them. And there are two articles that were actually published in 2003, that came out at the same time, kind of noting the same thing, that these were in blunt trauma patients, that about a quarter of the patients that come in, and generally these are patients who are in shock when they come in, they are coagulopathic, so they have abnormal either PT or PPT. And those patients that do have abnormal coagulation factors right when they hit the door, before we've done anything to them, their mortality is markedly increased, up to 4 times greater than the mortality of patients who don't come in with abnormal clotting factors or clotting studies. This was also validated a little bit later in penetrating trauma patients as well. So both this is seen in blunt and penetrating trauma. So this was actually really looked at in a little bit more detail in the PROMPT trial, which came out in 2013, I believe. And one of the lead authors on this trial, actually this component of the PROMPT trial, was Mitch Cohen, who was a resident with us and was a Cook County alum and a Rush University alumni, who's now in Denver. But he's done a lot of work with the PROMPT trial. And basically, I'll talk more about this later for the real reason why the PROMPT trial was designed. But this was kind of one of the spin-off papers that came out of it, looking at this acute traumatic coagulopathy. He found that almost over 40% of the patients came in with some kind of abnormal clotting factor. Now, again, this is a different group than what we talked about in those other ones. These are patients who actually come in and they actually receive blood. So these are patients who are being transfused. So these were sicker patients. So it's natural to expect that they're going to have a little bit higher incidence of this abnormality in their clotting cascade right when they get there. So pretty high number of patients here, and they actually did assays on all the different factors, and they found that there's just global decrease in all the factors, including fibrinogen. They did some mechanistic studies and found that it, not to get into the weeds too much, but it seems to be mediated through activated protein C, and what that leads to is increased breakdown of the clot that does form. So not only do you have your handicap as far as making the clot itself, but once that clot does get made, it gets broken down faster because of this other mechanism. So you have hyperfibrinolysis. So you've got poor clots being made, and then once they are made, if you're lucky enough to get any, then those are getting broken down faster. And this is going to be important because this is going to be a strategy that some of these adjuncts that we use for coagulation are going to try to target this. So back to damage control at that stage. So we see what the lethal triad is. So you get this coagulopathy, both the acquired and the coagulopathy that this patient's coming in with. So damage control resuscitation is, again, as I mentioned, two components. So stopping the bleeding and then this coagulopathy, dealing with that up front, now that we know what's going to happen to these patients. So what can we do about stopping the bleeding? So it can be done actually in the pre-hospital setting. There's a couple strategies which are described. So it's permissive hypotension is one, which is often talked about. It's not a new strategy. Again, this was right after World War I. Walter Canada was from the Harvard Medical Group and noticed that if you give a lot of fluid to some of these patients to try to get their blood pressure up, they actually start bleeding and they do worse and they lose more blood than patients that maybe if you didn't try to get their blood into something that makes us more comfortable, that those patients did better. So the theory being that you're able to form, or the patient's able to form a little bit of a clot, you get that blood pressure up and you pop that clot off of that little plug that it's making. So, so this was kind of the first mention of permissive hypotension. The real landmark paper actually didn't occur until 1994. It was published in the New England Journal, and it really miraculous. And this is Chicago Fire Department, because I had a picture of that, but it was done in Houston. There weren't any good pictures of Houston ambulances. So this was amazing they were able to do this study because it was a prospective randomized trial involving pre-hospital personnel. Which I don't know if you've tried to organize one of those before, but it is not easy to do. So they were able to do this. They were able to recruit almost 600 patients, all of them with penetrating torso injuries who were hypotensive, so less systolic blood pressure less than 90. And they divided them up into two groups. There was an immediate resuscitation who got fluids in the field, and then there was another group, the intervention group, which were ones that did not get fluid in the field. They didn't get fluid until they actually made it to the operating room and they're getting ready to have their operation started. So they found that there was actually a decrease in mortality in those that had delayed fluid, fewer complications, and decreased length of stay. So patients, if they were able to get the blood pressure, exactly what that map that they were trying to achieve was isn't very well delineated here, but will be in a later study. They were able to preserve that clot that was formed and not pop that clot off, get them to the operating room where you can actually surgically take care of their bleeding. Again, these were penetrating injuries. So this really reinforced what we do in America, which is really the scoop and run. You need to pick up patients as fast as possible and get them to a hospital. And in Chicago, we're fortunate we have 4 level 1 trauma centers in the Chicago area, so it's very easy. Run times are 50 minutes or less for all patients. Probably a little bit different here when you're getting transfers from far field and helicopters. But in the urban setting, this is certainly scoop and run is really what is improves mortality, as opposed to what's done in other countries, in Europe and other places where they do what we call stay and play. So they have physicians actually go out into the field and they do maneuvers out in the field, and then they bring them back to the hospital later. So delays their care a little bit more. We think ours is better. They think theirs is better. So this is another follow-up study. Actually, Maddox's group did this one as well as that original one. And it was a prospective controlled trial where they actually had an intervention group where they kept the MAPS at 50, and the regular group, which is we just treat with fluid as you would normally treat people, try to keep MAPS above 65. And they found that in the group that had the lower MAPS, they received less blood. Makes sense. The clot worked, and they got to the operating room, either laparotomies or thoracotomies in this group. And they were able to control the bleeding before that clot popped off. There didn't seem to be any difference in 30-day mortality, but there was a decrease, at least a trend towards a decrease in mortality, a trend towards a decrease in operative deaths, and a trend towards an improvement in the coagulopathy in patients who have the lower MAP goals. So now the military actually uses, if you look at the Joint Trauma System clinical practice guidelines, so they talk about permissive hypotension and really just titrating to radial pulse and mental status. So if they're mentating okay and you can feel a radial pulse, that's good enough. Don't give them any more fluid until they can get to a center where one of the 4 resuscitative centers. So damage control surgery is also not a new idea. It actually was in the early 1900s. Some of the luminaries of surgery as well as trauma who really, a lot of the initial work done here was really how to control bad liver bleeding. So these were patients who had injured livers. The Pringle maneuver developed in the early 1900s to control bad liver bleeding. Packing was also Halstead and Feliciano, Lucas, and Ledger all describe packing and how you can leave packs in that patient, get out of the operating room, and then come back, and then take those packs out, and hopefully that patient started clotting their blood at that time. But again, these were all really for liver bleeding. The first time it was really applied with preventing a lethal triad in mind was actually Harlan Stone in '83. Was the first. He didn't call it damage control; he called it bailout surgery at the time. It was called damage control surgery later. Rotundo and actually Feliciano kind of described it a little bit later in the '80s as just an abbreviated operation. And this is what it is. So you're just doing the minimum that needs to be done in the operating room, because we know bad things happen in the operating room. Patients get cold, anesthesia gives them a lot of pressors, and they give them bicarb instead of giving them blood products that they need. So we try to get out of the operating room as fast as possible. You need to control the surgical bleeding, and then you need to control any spillage from the GI tract. So a lot of times we'll just leave people in discontinuity if we need to, and you know that we're going to get out of the operating room as fast as we can, close them temporarily. This should be familiar to everybody who's been through trauma. We do this with a fair number of patients. And we resuscitate them hemostatically, we warm them up in the ICU, and we go back to the operating room in 24 to 48 hours, and we complete the rest of the surgery that we initially would want to do. Now, some patients, it's very obvious you're going to be damaged from from the very beginning. Patients who come in extremis, you get them up to the operating room, you know you're just going to do the fastest thing you can and get them out of the operating room and resuscitate them more. There's other patients that seem a little bit more stable, and when you get up in the operating room, you think you're going to be able to do a lot, and then you find out that their temperature is 33 degrees, and their base temperature just came back, it's getting worse, it's 11 or 12 now, their pH is 7.15, and then you're thinking, even though they might look okay, you need to switch into damage control mode. And we use a couple kind of indicators, at least for us, that make us think, even though this patient looks okay, I'm not going to do the anastomosis now. We're going to just stop. We're going to get out of here. We're going to resuscitate. And what we use is pretty well described. Temperature less than 34 degrees, we're done. And pH of less than 7.2, we're done. So we'll just stop. And also, you can see when patients become coagulopathic, they just start bleeding from places that they shouldn't be bleeding. So you control all of the arteries and how they bleed, but they start seeing just oozing from all the mucosal surfaces from IV sites. Once you get to that point, you're pretty much, it's too late. So you need the discipline to not say, I think I can get this anastomosis, I think I'll do this now. You just need to say, I got to stop, I will come back in 24 to 40 hours and finish the operation. Originally it was described for just abdominal operations, but we actually use it for damage control thoracotomies. We do just temporary shunts in peripheral vascular cases where we'll just put arterial shunts in and then get out of the operating room, come on back, and then do that definitive repair later. So it's being more broadly applied to areas other than just the abdomen. So hemostatic resuscitation. So once we're able to control the bleeding, and there's other things which I don't unfortunately have time to talk about as far as new mechanisms for controlling bleeding. Reboa is a big one which has gotten a lot of popularity lately, which we've started using Reboa at County, and some other things, but see that for another time. Hemostatic resuscitation. So once you get that bleeding stopped, and actually while you're getting that bleeding stopped, you need to address the lethal triad and the coagulopathy. So it really is made up of several components. You need to minimize crystalloids, because crystalloids cause problems, and we'll talk about that in a second. You need to proactively address the coagulopathy, and then think about there's some of these coagulation adjuncts that have been fairly popular in the literature. Some of them work, some of them don't work. So crystalloid, this is Tom Sharkey. It's a really neat, I was reading about some of the stuff that he had done, radio-labeled albumin and actually mapping of where the fluids travel in different body compartments. So he was really one of the pioneers in determining third spacing and how fluid travels in the body. And a very big proponent, crystalloid got a lot of popularity after his early work in the 60s. But he did realize that if you give too much crystalloid, that actually cells swell, and then you have decreased diffusion of oxygen, and that has its own problem. And then subsequently, we realized that there are other problems that are associated with crystalloid as well. Not least of which is just global swelling, abdominal compartment syndrome. People get swelling of their GI tract, they get fluid overload, and just a number of other problems. Their capillaries become more and more leaky as you give more fluid, because actually that crystalloid potentiates the leakiness in the capillaries themselves. And the fluid that we give also exacerbates the lethal triad, because normal saline, which we give lactated ringers normally, but normal saline or crystalloid, it actually is acidotic. It dilutes the clotting factors, and if you don't give it warm, then you're also going to increase their coagulopathy. So this is the 9th edition of ATLS. The 10th edition is practically out. It'll be actually probably rolled out in February or March, I think, of 2018. But they cut back, in the 9th edition, they cut back from the initial bolus of 2 liters of crystalloid to 1 liter of crystalloid. So everybody's and also warning against aggressive resuscitation. So with crystalloid. So crystalloid is kind of out. We're giving more blood up front now because we're recognizing the mortality benefits to giving blood. So if you're not going to give crystalloid, then what are you going to give? So we need to give blood. Back in before the 70s, whole blood was what was used. So it's not that practical. You can't store it as well. And from an economic standpoint, in the late 70s, it moved towards whole blood, towards blood components. So they fractionate all the donated blood into various components, packed cells, FFP, platelets, and cryo. And then they'd be able to kind of more effectively utilize that blood, give the component to the patient that needed that component rather than just give everybody whole blood. Back in the 70s, the theory for resuscitation was crystalloid, 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 and then if they got a shock, then give them some red blood cells, and then after they've gotten maybe 10 units of packed red cells, then maybe give some FFP, and then if you think about it, you give platelets, and then kind of tailor your resuscitation based on your PT, PTT coming back. So that kind of delays the resuscitation, but it was crystalloid up front, and then a lot of packed red cells. Kind of some anecdotal evidence came out of military experience in the 90s and early 2000s, where just because of the logistics of being in the military and these forward deployments, you can't store components. All they had was packed red cells. So they would use their walking blood bank. So everybody, all the soldiers are typed in prog, or they're typed. They've been screened for a lot of the diseases that we screen blood for now. So a soldier is injured and they know the blood type, they can call the person who's got that same blood type and they can give them a whole blood transfusion. So there was a fair amount of whole blood transfusions happening. And they looked at that and said, wow, these patients actually seem to be doing better than those that were giving a lot of just packed red cells to. So this kind of stimulated the idea that maybe we need to change our resuscitation thought and not just give packed cells, but maybe we need to do something maybe like whole blood or maybe more approximating whole blood. So really the landmark paper came out describing this was Boardman in 2007. And that really looked at, this was a retrospective look at military casualties in Iraq and Afghanistan, and found that the higher the ratio of FFP to packed red cells, the better that patient did. And it wasn't a subtle difference either. It was quite a big difference, 19% mortality versus over 60% mortality. So huge difference in patients that got majority packed red cells versus patients that got both FFP and got packed red cells. The civilian work kind of picked up on this as well, and a number of studies were done in the civilian population. And this is just a summary of some of them, all of them with ratios close, and they actually added platelets here, but close to 1 to 1 to 1, but it's kind of all over the place. So the optimum ratio was really not determined, but certainly something better than all red cells was better than just red cells. So that was really one of the reasons why the PROMPT trial came out. So there was 2 trials that came out to really address this issue, the PROMPT trial and the PROPER trial. And PROMPT was really looking at, it was an observational study, prospectively done, but really looking at transfusion practices in level 1 trauma centers all around the country. And all patients that were actually getting transfusions of more than 3 units of blood. So what they found was that the patients who ended up getting a closer FFP to packed red cell ratio did better. So closer to 1 to 1 ended up doing better. But also, what they found, this is a little hard to see from back there, but this is actually a time course of what the ratios were. So the light bar here, this is pure red cells. Then the darker bar here is close to 1 to 1 ratio, and this is for packed red cells to FFP, and this is packed red cells to platelets. So later on in the course of the resuscitation, dark bar gets higher and higher, so closer to a 1-to-1 ratio. So initially, patients are getting all red blood cells. In the first half hour, it seems to be all red blood cells. These are level 1 trauma centers that all have massive transfusion protocols. So you can see these are pretty well set up to deliver blood products quickly. And even in level 1 trauma centers, you're not getting that ratio up front, like you are, but you're catching up towards the end. And it's particularly pronounced with platelets. So the conclusions from the PROMPT trial is that higher plasma platelet ratios early in resuscitation are associated with decreased mortality. So the sooner you can get that ratio to closer to 1-to-1, the better the patients ended up doing. So it's not just the ratio itself, but it's how quickly you can get that ratio. So you want to get that first cooler of blood and not just have packed red cells in it and then wait for the FFP to thaw 30 minutes later and start giving that. But you want to have pre-thawed FFP. You want to give all those blood products together. So the proper trial actually looked at, as we saw earlier, some of the so during the studies, the ratios were kind of all over. So 1-to-1-to-1, that's FFP platelets to packed red cells versus the lower ratio, which would be FFP platelets to 2 of packed red cells. So which is better? Is there a difference in mortality between these groups? It seems sort of subtle, but want to isolate which is the best ratio. And basically what they found was there wasn't any difference in mortality. However, there did seem to be improvement in achieving hemostasis when you actually give all the blood products up front and in the 1-to-1 ratio. So 1-to-1-to-1 seems like it's better than 1-to-1-to-2. And that's really what most centers are going to now. We're trying to get as close to 1-to-1-to-1 as possible. And really want to focus on getting that ratio achieved early on rather than just waiting to catch up with that ratio. So you need to develop systems that are enabling you to get that blood quickly to the right place in the proper ratios right up front. So there's some hemostatic adjuncts which have become popular. These are 2 that we'll talk about. So activated factor 7, which is Nova 7, and then TXA. So factor 7 really, most of the use of factor 7 is off-label. About 90% is off-label. The only indications really for factor 7 is hemophilia with inhibitors and people with a congenital factor 7 deficiency. But it was first described in 1999 as for use in traumatically bleeding patients. So it had a lot of enthusiasm initially. Some of the early studies that were retrospective seemed very promising. A lot of these were lung trauma patients. We were actually part of the control trial, and that actually increased the eligible pool to lung as well as penetrating trauma. And we gave pretty high doses of factor 7. We were given 200 micrograms initially, then 100 and another 100. So that's much higher than a lot of other studies we looked at. We actually had to stop the study early because there was no mortality benefit. So interestingly, and it was very protocolized, so not just how you give the blood, how you give the factor 7 was protocolized, but how we manage the patient in the ICU, vet strategies, things like that were all very protocolized. And it's interesting, the comment that was in the conclusion was modern evidence-based trauma lowers mortality, paradoxically making outcome studies increasingly difficult. So we've done such a good job of actually improving our care for patients that now we're not able to study what we're doing as effectively. So I guess that's a backhanded compliment. In case you still are excited about factor 7, this is actually a forest plot which shows all the retrospective and randomized control trials looking at factor 7 in trauma. And there's only one that seems to show there's a benefit to factor 7. All the rest are straddling the line, so no statistically significant benefit to factor 7. And if you're still thinking about using it, then there's actually a number of reports of increased thrombotic risk, particularly arterial thrombosis in patients. This was a study actually that was in the New England Journal that looked at 35 off-label studies of use of factor 7 and found there was a same incidence as far as venous thrombosis goes, but an increased incidence of arterial thrombosis. And anecdotally, we used to use a fair amount of factor 7, and there was a lot of pulmonary complications, a lot of thrombotic episodes that we were able to see. So really, I'm just make the pharmacy happy, or actually probably the administration, because it's really expensive. Not recommended in trauma anytime. But TXA, on the other hand, is cheap. And actually there seemed to be some evidence that TXA might actually be a benefit. So what does TXA do? It actually inhibits fibrinolysis. So we saw the acute traumatic coagulopathy is a hyperfibrinolysis. So this is actually, it blocks fibrinolysis. And it's been on the market for a number of years. Again, this is off-label. We like to use a lot of things off-label in trauma. But the CRASH 2 trial that really got people excited about TXA. And it's an amazing, at least on paper it sounds amazing, randomized controlled trial, 40 countries, 20,000 patients, some receiving TXA, some not receiving TXA. And really, it's very hard to see, but kind of in general, it shows that all-cause mortality decreased by absolute 1.5%, and bleeding mortality decreased by 28%. But really, the mortality benefit was seen in patients that received it in 3 hours or less. If you received it in more than 3 hours after injury, your mortality actually went up. So really the conclusion from this was, and if you look at the relative risk, so the relative risk of death from bleeding was actually much more substantial in the bleeding death cohort. But again, that relative risk of dying was significantly lower for patients who received it in less than 3 hours. So don't give it to patients beyond 3 hours, just for the 3 hour.
Is that first dose?
First dose. Right, because the second dose goes over 8 hours.
Right.
So
Okay.
first dose is 10 minutes, second dose 8 hours. So this was followed up in the MATTERS trial, which was actually looking at military patients. They had 4 groups, some that received TXA and had a massive transfusion, so no TXA and massive transfusion. And basically they found that overall the mortality was decreased in hospital mortality. The TXA group 17.5% versus 23%. More pronounced in the patients that have massive transfusion. So in massive transfusion patients, this seemed to be even more beneficial. So a markedly decreased mortality in patients that receive TXA in the massively transfused patient group. So how do we use it? We give it, it's part of our MTP now, so all patients that we're doing a massive transfusion on, we make sure we give it to patients as long as it's within 3 hours. We just looked at our MTPs. Like I said, we do about 75 MTPs a year. We just looked at our ones from penetrating trauma and found that only 20% of them actually got TXA. So even though we know about it and we think about it, we aren't actually giving it. So that's kind of a logistic challenge that we have. And we put up all these signs afterwards. They're all over the place now. We'll see if that has any effects. Usually we're not staring up at the wall when that patient comes in. But it's part of our care sets now, so when we're ordering massive transfusion protocol, it's just a box to check, and then the TXA order gets put in as well. But the real problem is we often give it initially, but then it's that second dose, because often we're going up to the operating room, and there's anesthesia, have it upstairs, or do we bring it, and they start hanging it when we get upstairs, and that's not always what we're thinking about as our top priority. So lastly, I want to just finish up with who needs damage control resuscitation. So obviously not everybody needs it, and probably there's some harm to doing it on people who don't need it. And in fact, that was looked at. But we know that blood transfusions in general used to be given before the good immunosuppression. Blood transfusions are immunosuppressants given for transplant patients. But actually this was looked at by Kenji and Naba out in LA County. And they looked at what happened to patients that got large doses of FFP, but then they ended up not needing a massive transfusion. So they didn't go on to that next step where they got the massive transfusion, but they gave them a fair amount of FFP up front. And those patients, there was no survival increase or decrease in the patients that got a lot of FFP, but they did notice a marked increase in complications, particularly ARDS. So these patients, they didn't necessarily die, but they got complications that kept them in the hospital longer. So you don't want to start it on everybody and give them all that FFP up front, but you need to somehow figure out which patients are going to be better suited for, or who's going to need an MTP and who's not going to need a massive transfusion. So there's a couple ways that you can identify those people. One, see are they in shock. That's probably not the best because you need to lose quite a bit of blood before they're going to be hypotensive, and some of the signs of shock might be a little bit more subtle. So then the shock index was created, and if you have a shock index greater than 0.9, then maybe you'll need it. But really a number of scores came out, and scoring systems, some of them easier than others to use. An app is created for this one down here, which is kind of neat, so you can have it on your iPhone and kind of calculate it fairly quickly. But one that's probably used the most, because it's the easiest, is the ABC, the assessment of blood consumption. That was actually what was used when patients were enrolled in the proper trial. So they use physician judgment, which is always the case in all of these studies, but assisted by the ABC score. So an ABC score of 2 or greater was used in order to sign people up, and they're going to be in that MPP group. This just compares some of the features of the different scoring system. Basically, there's usually a physiologic component and an anatomic component. So the ABC score looks at systolic blood pressure and heart rate, but then also it looks at fast. And if it's a fast, if they see fluid in any area on the fast, then that you get a tick for that. And then is it a penetrating mechanism? You get a point for that. And it's only 0 to 4 points. Skip that. So the ABC score, again, this is what just the 4 factors that are being used. And they found that if you have all 4 of these, your chance of having being an MTP are about 100%. So if it's 2 or greater, it's about 40% again, be an MTP. So this really is what we use, a modification of this. So we'll use heart rate, we use blood pressure, physician judgment always comes in there, and we also use base deficit of 7 or worse. So if they have those, then we activate our MTP. So I think that's about the time I have, but so in conclusion, damage control resuscitation really is preemptive treatment of the lethal triad, so we know what happens, the acidosis, the hypothermia, the coagulopathy, so addressing that early on to prevent that triad from happening. There's 2 different kinds of coagulopathy that we're preventing, and controlling bleeding is important. There are a couple strategies that seem to be helpful in controlling bleeding, but you got to get that surgical bleeding stopped, and there might be some adjuncts that might be helpful for getting that bleeding stopped. Factor 7 is not one of them. It's not recommended now. TXA is something that we're using. TXA now, there's not a lot of downside to using TXA. It's not expensive, and the complications rate don't seem to be increased with TXA. And then you need to just carefully select which patients you're going to get it, because you don't want to give massive transfusions to people who don't ultimately need them. That's it.